Good evening, everyone present today. Well, the topic for today is community acquired pneumonia sepsis septic shock, and our organizers are Dr. Aklesh Tandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal. And the speaker for today's class is Dr. Suresh Ramasubban, who is a HOD and Director Depth of Critical Care Medicine in Apollo Multispeciality Hospital, Kolkata. Doctor, you may start.
Thank you very much.
Good evening, sir.
Good evening, yeah. Thanks very much, Asif, for having me over. So this was supposed to be community acquired pneumonia and sepsis and septic shock. So I'm gonna, because I have 60, 70 slides, I'm gonna leave it only to community acquired pneumonia, and we'll discuss. Obviously, septic shock is a topic by itself. So I will, Asif, you'll have to pardon me for truncating the topic a little bit. So what I'm going to cover is with a little bit of clinical case scenarios and multiple choice questions thrown in between to see how you guys are, people who are interested in following this. All right. So the objective is to talk about the epidemiology of CAP, the clinical diagnosis, what is the microbiology, how do you diagnostically evaluate in the era of PCR testing, where do you manage the patient, what antimicrobials, what's the role of steroids, and what are the various complications that can happen with community acquired pneumonia. All right. So community acquired pneumonia, just for epidemiological purpose, it's the leading cause of infection and hospitalization in the United States, and probably the same is true for every part of the world, and is associated with more than 10 billion annually in healthcare expenditure. So, and again, it's a lot of it is preventable. Influenza is preventable, so we should vaccinate. Pneumonia is preventable. Again, same with especially the severe CAP is preventable with the pneumococcal vaccination, and therefore the understanding the fact that we're spending almost $10 billion annually is important to understand. It's the sixth leading cause of death in the United States and the leading cause of death due to infectious disease in the US. And post-COVID, and this data is from before the COVID, and after COVID, we will probably see a lot more that it has become probably a very important cause of infectious disease death in the United States or across the world where COVID is spread. The spectrum of illness that you see with community acquired pneumonia ranges from people who walk into your outpatient department to people who don't even come to the hospital, they just shrug it off, to about 50% of patients therefore are managed in the ambulatory setting in the pulmonary OPD, and they never see the eyes of an intensivist, and it's something which is for them it's unusual to get into the hospital. Rates of hospitalization obviously increases as you get older, and among adults 80 years or older is 25 times higher than in adults younger than 50 years. So a pneumonia in an elderly age group of 80 plus, you're going to have a 25 times higher chance that you're going to get hospitalized as compared to somebody who's less than 50 years. So with this background of the importance of community acquired pneumonia, I just want to go through a kind of a short case vignette and give you an idea as to what's happening. So this is a 65-year-old male with past medical history of diabetes, comes to the outpatient department with a 2-week history of cold and cough, a 2-day history of shortness of breath. He's unable to sleep the night before because of breathing problems. So just an overnight breathlessness, which has gotten worse. And he's got a low-grade fever for the last 3 to 4 days. And there's a decreased urine output and decreased oral intake for the last 24 hours. So this kind of gives you a good idea as to what this patient might have. And the history is pointing towards a pneumonic process. And that's what we are seeing on this X-ray, that he's on physical examination. We are noticing that he's tachycardic and tachypneic. He's non-cyanotic. Blood pressure is 150/60, temperature of 100. There's right base crackles. He's got cardiovascular examination is normal except for a tachycardia, and the rest of the physical examination is normal. He's awake and alert, and probably not showing any focal deficit, and abdomen is soft. So the clinical diagnosis of pneumonia can be made, community acquired pneumonia, by understanding what's the definition. So a pneumon, the word pneumon is why we call it pneumonia and not a alveolitis or a pulmonitis, is because pneumon is the Greek word for lungs, and pneumonia and pneumonitis therefore means inflammation of the lungs, and pneumonia is therefore a very non-specific term for disease of the lungs, because you understand that we also call interstitial lung disease like UIP. It's also called usual interstitial pneumonia. So that's also doesn't mean that it's the same pneumonia as what we are talking about today. So community acquired pneumonias, and when you say infectious pneumonias, are different from interstitial pneumonias like UIP, DIP, and so on. Pneumon just means lungs, and pneumonia is disease of the lungs. Pneumonia is defined as an inflammation of the alveoli at distal airways and interstitium of the lungs. So the alveoli in this case are going to be filled with inflammatory exudates with white blood cells, red blood cells, and fibrin. And this is what you will see in the radiology as a airspace opacity. So pathologically, it is going to be characterized by a consolidation, and that's what you're going to be seeing. Sorry, I got to let my dog come in. Come in, Muni. Otherwise, he's going to bark outside the door. Sorry about that. So, pathologically, a pneumonia is characterized by consolidation. And clinically, you have a constellation of symptoms and signs that's gonna be present in patients with pneumonia. So this is what the origin of the word pneumonia and how the pathologically it's gonna be. So definition wise, pneumonia is a clinical syndrome compatible with a lower respiratory tract infection. So that's why that means you have fever, cough, and breathlessness. That's a standard lower respiratory tract infection associated with consolidation seen on a plain X-ray, together with the identification of a respiratory pathogen from a clinical specimen like a sputum or a throat swab, or this thing which will identify a viral pathogen. So this is and if this comes from a patient who is in the community, it's called as community acquired pneumonia, which is the title of the talk today is CAP, or community acquired pneumonia. So it's a pneumonia is a clinical syndrome not diagnosed solely on the basis of the X-ray, because and not solely diagnosed on the basis of a lower respiratory tract symptom, because a cough and shortness of breath can be heart failure. A cough and breathlessness can just be a bronchitis or an asthma exacerbation or a COPD exacerbation. So you have to have a plain X-ray consolidation seen on an X-ray together with identification to be confidently be able to call that this is a mnemonic process that's happening. The pathophysiology of CAP can be pathogenesis of CAP can be seen from this kind of a flow sheet, where you have a CAP with a physiological inflammatory syndrome, where you have a local inflammation in the pneumon, in the alveoli or the terminal bronchioles or the interstitium, which leads to cough, shortness of sputum production, shortness of breath, pleuritic chest pain, tachypnea, dullness to percussion, RAS, hypoxemia, and pulmonary infiltrates. It can progress further to have systemic inflammatory response. That's why you have the fever, chills, tachycardia, tachypnea, leukocytosis or leukopenia, increased CRP, increased ESR. And when it goes to a dysregulated inflammatory response, which is the definition of sepsis, which is what when we call it severe CAP. So severe CAP and sepsis, there's hardly any difference. Basically, when you have infection leading to a dysregulated inflammatory response, that's what we call as sepsis. And this kind of graph very clearly illustrates that when you have dysregulated inflammatory response, you have organ dysfunction, organ failures, and multiple organ dysfunction syndrome. And the organ dysfunction, the most common organ dysfunction, as in our case, Vineyard, is confusion, which is what you will see. Otherwise, they have nothing else. You can have thrombocytopenia, uremia, hyperlactatemia, and you can have pure organ failure with cardiovascular failure, respiratory failure, renal failure, neurological failure, hematological failure, and so on and so forth. So all these things are going to be the pathophysiological response, where you have inflammation in your alveoli spreading out into the systemic fashion, producing inflammation, or getting dysregulated and producing a severe CAP, which has sepsis manifestation with organ failure. So this is the why we have the Asif combined this topic of CAP with sepsis and severe sepsis, because eventually CAP will lead to, in the physiology, pathogenesis will lead to dysregulated inflammatory response and will present as a severe CAP. And we'll talk about the major and minor criteria as we go ahead a little further. So the clinical diagnosis of SCAP is made on the fact that you have a symptom suggestive of pneumonia, which is a lower respiratory symptom. That is fever combined with respiratory symptoms such as cough, sputum production, pleurisy, and dyspnea. So you got to understand that this is not enough, because this is might be an AECOPD, this might be an acute asthma exacerbation, all will have the same kind of a thing. But the physical findings of fever in 80% of patients will have it, and most will have a respiratory rate exceeding 20 per minute. Crackles are heard on auscultation in 80%, and 30% will have
Person
signs of
related and
consolidation.
cesarean. And in
This
previous
was
service, candidiasis and cryptococcal. And at least make
hello.
candidiasis, cryptococcal, and what would it be?
And when you have signs of consolidation, which is what we expect you guys to know when we ask in the exams, and the things that we are expected to demonstrate in an exam in any part of the world, is what are the signs of consolidation. So this is something which is absolutely we've been taught from medical college how to do this. So you got to see that you will have when you inspect the chest, you're going to have expansion of the thorax on inspiration is reduced on the affected side. On palpation, there may be vocal fremitus, which may be increased on the affected side. Percussion will be dull on the affected side, but remember, it will not be stony dull. Breath sounds are bronchial, and there will be a possible medium, late, or pan inspiratory crackles. Again, and vocal resonance is increased, or you might find what is called as whispered pectoral. Okay. All these are important signs that you should be able to pick up, demonstrate, and what do you say, be able to elicit when you're examining a patient and demonstrate it to the examiner when you have a case of a community acquired pneumonia. So it's very important to do it in the finding. And when you say diagnosis of clinical diagnosis, you have to go back and say the signs of consolidation are present. But remember, the signs of consolidation will be present only in about 30% of the patients, where we have a significant amount of consolidation on that can be picked up by our inspection, palpation, percussion, and auscultation. So this is something which you guys have to remember, the signs of consolidation. So in a compatible symptom, compatible findings of tachypnea, crackles, and signs of consolidation, you might think, like in our patient, I just presented that he has crackles on examination in the right lower side. That's all. I didn't show you any signs of consolidation, because so 30% of the time only we'll see this, but crackles can be present irrespective of whether there's signs of consolidation or not. So that's the clinical part of this. So a community acquired pneumonia, as I said, is a pneumonia which is happening outside a hospital, or from which you develop in the community, and therefore it's community acquired pneumonia. So obviously you have criteria to call it as severe, which is what, as I said, majority 50% are treated in the ambulatory basis, only 50% come into the ICU area. So the criteria for severe community acquired pneumonia, the major criteria is that you are either ventilated invasively or you have septic shock with a need for vasopressor. So once you have these two, you have this thing, or you can have any two of any three, any of these three: respiratory rate more than 30, PF ratio less than 20 to 50, multilobar infiltrates, confusion, uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension. So these are the criteria that we use for a cap. So question comes in a country like ours is, can you diagnose cap without x-ray? Because it is not very easy to get an x-ray even in a good hospital, because it takes 3 to 4 hours, and sometimes comes to a hospital, a busy hospital emergency, it takes some times. So again, once you have a symptom of an acute lower respiratory tract infection, that is cough plus dyspnea, pleuritic pain, or shortness of breath, plus new focal chest signs of in examination, focal signs of consolidation, as we just showed to you, then you can say that yes, it is possible, along with a systemic inflammatory sign of fever, or shivers or myalgia, and no other explanation for the illness, you can kind of diagnose cap without chest X-ray. So, but unfortunately, or most of the diagnosis of guidelines for the management of community acquired, including this one from the Chest Society of India and the NCCP, say very clearly that whenever feasible, a chest radiograph should be obtained on all patients suspected of having CAP. Again, in the absence of availability of chest radiograph, which should not happen in a majority of good setting and should not happen if you have an intensive care unit, that should be the basis of clinical suspicion. Do we scan everybody in the post-COVID era? We are scanning everybody, but is it recommended? And the answer is, if you look at the ATS IDSA guidelines from 2019, which were done before the COVID era, it says should not be performed routinely in patients with CAP. And CT scan should only be performed in those with non-resolving pneumonia, and to assess for the complications of CAP, which we'll talk about in the end of the talk here. So that's the role of CT. But now, there is a good this thing that if you have lower respiratory symptoms and your chest X-ray is not picking up, you might be okay in doing it. But as I said, as of now, the guidelines haven't changed. Practice has changed, and the majority of us in many of the ICUs, many of the this thing will probably be ending up doing a CT scan. But the answer in the fact is that you don't need a CT scan to diagnose CAP. CAP is a radiological, can be done with a chest X-ray, and can also be done without a chest X-ray if you have a clinical symptoms compatible with pneumonia and signs compatible with pneumonia that you can elicit, and then you can do it. Once you've diagnosed the CAP on the basis of clinical symptoms, signs, radiology, then comes is you have to diagnose the third important component of CAP, that is what is the microbiology. So the recommendations for what microbiology to obtain have changed over time. And but to understand that, you need to know what are the various etiology of microbiology of CAP that you need to be aware of. If you were to put it in a question, so this is one of the questions, and I think you guys can answer it yourself and say the most common etiological agent in CAP in a patient with no other comorbidity includes all of the following except. So these are the what is called as the core pathogens which cause community-acquired pneumonia. And the answer is obviously Pseudomonas in a patient without structural lung disease is not a common cause of community-acquired pneumonia. So strep pneumo, H. influenza, and Moraxella catarrhalis are the three typical organisms, and Legionella and Mycoplasma are the two atypical organisms. So the five organisms which cause CAP, that is the other way of asking this question, is strep pneumo, H. influenzae, Moraxella catarrhalis, Legionella pneumonia, and Mycoplasma pneumonia. And this is the five, out of them, three are typical and two are atypical organisms. And this is what is the common microbiological etiology. So the common or core etiology is the gram positive is strep pneumo. It can be methicillin susceptible staph, strep pyogenes, and other streptococci. You have gram-negative bacteria like H. influenzae and Moraxella catarrhalis, and Enterobacteriaceae, especially Klebsiella, can happen. And I'll show you data from India where we say that there is significant amount of Klebsiella that we see. Atypical Legionella pneumophilia and Mycoplasma pneumonia and Chlamydia pneumoniae. While respiratory viruses like influenza, COVID, RSV, we call this as the three Brahma, Vishnu, Shiva, that is influenza, SARS-CoV-2, and RSV. While others like parainfluenza, human metapneumo, rhino, common human coronaviruses are also very commonly seen when we do a respiratory pathogen. So this is probably a better idea of putting it rather than the five common cause. I think this is called as a core organism. So we need to understand there are core gram positive, there are core gram negative. India may be a little bit more of Enterobacteriaceae, and we will show you data for that. As rest of the world is predominantly gram positive bacteria, with strep pneumonia being the number one cause. And respiratory viruses are very frequently are coming up very significantly, maybe because we are picking it up much more because of the availability of the viral panels and the PCR testing that we do nowadays. But or maybe it is just that they are nowadays flourishing and we don't know that. The uncommon or infrequent organism include MRSA, nocardia. We see that a lot with immunosuppressed host.
यहाँ से VSA ले आओ ना VSA 3
And the gram negative is the Enterobacteriaceae, including the ESBLs or CREs, and non-fermenting like Pseudomonas or Acinetobacter, and organism like tularemia, which is a gram negative bacteria. When if you handle rabbits, it can happen. Atypical bacteria like chlamydia, again, psittacosis happens with bird droppings, coxiella, mycobacteria. In our country, tuberculosis is a very important cause of CAP. Non-tuberculous mycobacteria also is another issue. CMV, HSV, varicella zoster, MERS-CoV, and in fungi like pneumocystis, aspergillus, mucorale, histoplasma, and so on, and parasites like strongyloides and toxo. So you have very uncommon or infrequent, but when we try to treat CAP, we are only concerned with the common or core group only when people don't respond are we trying to include organisms which are extended spectrum to cover for atypical or uncommon or infrequent organism. So again, to put it back into perspective, this is from an older Lancet article which looks at these as the 5, 6 common in this order. But I think the previous table is probably the better one of looking at because this is 2023 NEJM review article, and this is probably the best way to look at the cause of community acquired pneumonia. Severe pneumonia, again, same thing. It's again severe strep species, about 52%. Staph 5H influenza. It's nothing changes even there. So severity is got nothing to do with bad organism. Severity has just got to do with the virulence of the organism, and strep pneumo is very virulent to cause a severe cap. So scap doesn't change. All right, one more question. A 45-year-old man evaluated for 3-day history of fever, myalgia, headache, and non-productive cough. He works as a large animal veterinarian. Medical history is unremarkable and he takes no medication. He's a middle-aged man. He's got a temperature. He's got a saturation low, 94%. And otherwise, you're not, as I said, so you need a chest X-ray to diagnose pneumonia in this situation. So you do a chest X-ray and it shows a patchy right lower lobe interstitial infiltrate. Question is, which of the following is the most likely cause of his illness? So you have choices like Bacillus anthracis, which is a cause of anthrax, Coxiella burnetii, which is a cause of Q fever, Chlamydia psittaci, which is a cause of psittacosis, Francisella tularensis, and Yersinia pestis. We'll find out. So people are coming up with different answers, and the next couple of slides will tell you the answers. So people can still think about the answers. What is the organism? So the key is to look at. He's a large animal veterinarian. He doesn't deal with dogs and cats, and he doesn't deal with rabbits, which is the cause of tularemia. He doesn't deal with rats, which is the cause of Yersinia pestis, and he doesn't deal with birds, so probably unlikely to be having psittacosis and so on. So we'll take a look at this. So what you now have is what is called as the what are the having a risk factor, and then what is the what are the organisms that you can have based on the risk factors. So if you have a heavy alcoholic, you have strep pneumo, aspiration of oral flora or Klebsiella. If you have COPD, you have Pseudomonas coming up. If you have structural lung disease, then Pseudomonas really goes up with the bronchiectasis and cystic fibrosis, Burkholderia, Stenotrophomonas, and staph. If you have aspiration, then it's oral anaerobes. If you have more than 65, then it's in viruses with strep pneumo. Viral illness, you get the staph aureus again. And then if you have animal exposure, if you have birds, you get psittacosis, histo, crypto. If you have dogs, you get Bordetella. If you have cats, you get Pasteurella. If you have farm animals, you get Coxiella burnetii, which is what the answer was. And if you have horses, you have Rhodococcus. If you have recent rodent droppings, hantavirus, and rabbits is Francisella tularensis. So if you're a large animal veterinarian, that means you're dealing with cows and sheep and things like that, you're going to be dealing mostly with Coxiella burnetii or Brucella species as a cause. And the choices that we have given you was Coxiella burnetii would be the common cause of a community acquired pneumonia. So again, these kind of hints in the exam is like somebody has been hunting rabbits, that tells you it's tularemia. Somebody who's been, as I said, large animal veterinarian tells you that. Somebody who's a bird fancier will be chlamydophilia. So on and so forth. Who's been cleaning the cages of birds, again, histo, chlamydia. So all these chlamydophilia, psittacosis, this is what you really need to remember. Again, these are epidemiologically important etiological organism. Harrison has a very nice, the tables is from Harrison's. So they have an internal medicine textbook. So you have to identify that. Otherwise, pneumonia, you have to get the hints, whether it's basically a risk factor of their alcohol, COPD, structural lung disease, or their exposure history, or even exposure like where are you coming from. So for in the US, if you're in eastern United States, you have histo, southwestern United States, coccidoides, and so on and so forth. If you're coming from Saudi Arabia, it's Middle Eastern respiratory viruses. If you're in late fall, winter, early spring in the Western Hemisphere, it's influenza. So all these things will change depending on the exposure history and what your epidemiology of it. In India, this is a very interesting question. When do you suspect influenza in India? So is it cold season or winter? So are we following the northern hemisphere? Or is it hot season or summer? Are we following the southern hemisphere? Or is it during the monsoon, that is from July to September? Or is it during the retreating monsoon, October to 19 November? Or is it year round? So something which pulmonologists will again, not many people think about it, but because of the change in weather in India, we see influenza year around with a few spikes in monsoons that we see. All our ECMOs for influenzas have somehow happened in May, June, July, rather than in the classical winter season. So so it is throughout the year around that we see in a country like us. Very so year around is what you will see. All right. This is an old question. The commonest cause of CAP in 2020 was, and the answer was absolutely COVID. So obviously, viral etiology is changing, and there are certain radiological patterns which will tell you what is the etiology. Remember, in the COVID, we had the CT, and we would see peripheral GGOs, and this thing which will be suggestive of COVID. We didn't even need to do a wait for a COVID RT-PCR, and we would just look at the CT and say this is COVID. So similarly, if you have lobar pneumonia, you know it's strep pneumo. If it's right lower lobe only, then you can suspect oral anaerobes, like the X-ray that we had. You can suspect aspiration if it's an older gentleman. If you have a lung abscess, then you have again oral anaerobes and nocardia and mycobacteria and endemic fungi. So on, pleural effusion, Staph aureus, and so on. And so the radiographic patterns also will tell you some little list, but radiography, if you see a patchy pneumonitis, it can be anything under the sun. It really will not tell you. All right. So what, as I said, the changing epidemiology in the post-COVID era is that a leading cause of CAP nowadays is probably viruses. More than 35 to 40% of our CAP is actually viruses, with the triumvirate of RSV, influenza, and COVID leading the pack. And then subsequently, strep pneumo is still number one in causing severe CAP, leading to hospitalization. But in 2021-22, viruses probably were leading the roost, and they were the number one leaders. All right. Again, this is from the EPIC study, again published in the community-acquired pneumonia. If you look at it, viruses are 23%. 62% of the time, you're not able to isolate anything. Strep pneumo is 5%. Legionella is 1%. So everything so viruses are known in about 25%, and virus plus bacteria co-infection is about 3%. So in US adults who require hospitalization, this is the almost 62% of the time you have no organism isolated. So in India, probably it will be about 90% of the time that we don't detect anything. All right. So if you look at the Indian etiology and look at what it is, so Klebsiella pneumonia becomes a lot important when you look at hospitalized patient, community acquired. Staph is also there, E. coli, beta hemolytic. So the Enterobacteriaceae come up a little bit more. This is from Srinagar. Again, Pseudomonas is the commonest pathogen, but they have probably had a lot more structural lung disease like COPD, from where this is coming. Shere Kashmir is a big pulmonary institute, so maybe biased. Again, in this patient, it was almost 65% with smokers, COPD 57%. So therefore, the Pseudomonas, as you say, comes up significantly. TB as an etiological agent of CAP, if you look at international studies, in South Africa, it's pretty common, 39.6%. And in Malaysia, also the study which says almost 47% of CAP TB can be isolated. In Legionella in India, again, 2.55% from a study in Tirupati. Again, in the All India Institute, again 13% of patients had a recent conversion to seroconversion. So Legionella also becomes very important. Mycoplasma study. Again, there's a bias when people do the study that they means they have a new testing methodology, and there's AIMS and PGI are trying that out. So you get to tend to see a lot more people with that particular kind of pneumonia during the testing phase. So maybe, but we still know that atypicals are what these last two slides present, is that atypical organisms are important in India. What the more important thing is there what is the incidence of drug-resistant strep pneumo? In the US, penicillin resistance can be as high as 35%, and about 15.7% isolates were intermediate sensitive. So when you look at the BTS guidelines, it will say amoxicillin is good enough. European guidelines will say amoxicillin is good enough for outpatient data. But certain parts of Spain, where the DRSP rates are high, maybe penicillin resistance. In the US, where it's 35%, you will have a significant amount of treatment failure when you do outpatient treatment with amoxicillin. Maybe that's why you need to use azithromycin or doxycycline out there. And similarly, in our country, we really don't have very good data, but we know that DRSP rates are still less than 4% in our country as far as severe strep pneumo infections are concerned. So probably we don't have that much of a worry of having failure with treatment of strep pneumo. Right. So the people who are at high risk for infection with beta-lactam strep pneumo include elderly, young people, alcoholics, medical comorbidities, immunosuppressive illness, and daycare center child exposure who's in a child in a daycare center. So in India, as I said, intermediate resistance is 1.3%, and the ANSOP study has shown there's an incidence of 3.8% to 4% in India. So we are still not that bad as far as drug-resistant strep pneumo is concerned. So moving ahead with the diet, once we understand that we need to have the etiology, microbial etiology also as the third component of our diagnostic evaluation. So you'd have the constellation of clinical features, symptoms, signs of consolidation, chest X-ray. You require microbiological data, and patient with CAP should be investigated for specific pathogens that will alter your standard treatment. If you think it's not going to change yourself after this thing, you don't need to. And especially you need to think of TB in our country and send sputum for AFB if you think that the findings are not very typical or the patient is at risk for tuberculosis. Blood cultures, positive results in only about 5 to 14% in large unselected CAP. The only time you have to and must do a blood culture in CAP is when you have severe CAP. That means you make either the major or the minor criteria, and you think of pathogens other than strep pneumo, staph, pseudomonas, and other gram negatives. So blood culture should be sent. Sputum gram stain. Again, only 10 to 30% patient will have a non-productive cough. So even if you write for a sputum, they'll not be able to give it. And most of the time, even by the time they produce a sputum, they've already received the antibiotics. And 30 to 65% of cultures of expectorated sputum are negative. So again, sputum is sent only when you have a severe CAP. That's when you absolutely have to do it. The other thing is to test for urinary pneumococcal antigen. It's not required routinely. Again, pneumococcal PCR is not recommended routinely. Legionella is desirable in patients with severe CAP, Legionella urine antigen, and investigation for atypical pathogens need not be routinely done. But if you are getting a comprehensive panel, you will get these things answered in a systematic fashion. So, but again, you don't need to routinely do these things because of the cost involved of doing a comprehensive respiratory panel. So it is better to treat for atypical organisms when you have a typical community-acquired pneumonia. As I said, this is the guidelines from the 2019. So sputum culture is now recommended in patients with severe disease as well as somebody who's been treated for MRSA or Pseudomonas, and blood culture is now recommended with patients with severe disease. So sputum culture are also ordered in patients who are hospitalized or received parenteral antibiotics within the last 90 days because you have a high chance that you'll find an enterobacteriaceae or a drug-resistant bacteria. And anybody who has a cavitation should have or a structural lung disease like bronchiectasis or cystic fibrosis should always have a sputum gram stain and culture done. And in case of cavitation, you should always consider mycobacterial or fungal causes and send appropriate AFB stain and fungal stain also. Viruses, as we said, is nucleic acid amplification, a positive in up to 40%. And but unfortunately, sometimes we don't know whether they're an adenovirus is a true pathogen or is it just a concomitant there. But again, it is something which we really need to do it if it's available and if it's cost effective. Procalcitonin, it's again useful in distinguishing CAP from acute bronchitis. There's no role in deciding treatment in established. Once you have a pneumonia X-ray with a pneumonia, it only probably will not add anything. You need to start antibiotics irrespective of what the procal is. If you have a clinical symptom and signs of pneumonia along with an abnormal X-ray, which is showing features of consolidation. If you have features of pneumonia on an X-ray, your symptoms and signs are all matching, irrespective of the procalcitonin, you need to initiate antibiotics and you can't wait for that. But if you don't have the compatible clinical and radiological features, then the procal might help us in not giving antibiotics as something which we can think of in doing this. The more important thing for emergency physicians and for doctors who are admitting patients rather than intensive care physician is when we get a patient like with who's non-severe cap or who's requiring, where do you admit this patient who comes to the emergency department? Where do you admit them? What's the site of care? So commonly the suggestion that we always have is use the curb 65 score, which is confusion, uremia, respiratory rate more than 32, low blood pressure less than 90 SBP, and age 65 years or greater, to decide whether the patient requires to come into the hospital or you can manage as an outpatient. Once you come into the hospital, you have certain more important clinical decision support system, and we suggest that these are the two decision support system: the PSI pneumonia severity index or the IDSA ATS criteria, to decide where to admit. If you have major criteria, obviously then you need to come into the ICU. If you have minor criteria only, you need to come to the hospital ward, and we need to have a close monitoring of your oxygenation and all these other parameters. So as I said, you can use any one of these things to calculate, and these are easily available. The easiest to remember is the IDSA and the ATS criteria. Again, these are published in 2019, and these are still valid to decide where do you want to this thing. So this is a PSI is the most validated index and is for identifying where to care for the patient. It predicts all-cause mortality at 30 days. So there are 11 variables, and patients with no risk factors can be managed as outpatients. Those with one risk factors are stratified accordingly to between 2 and 5. And the PSI is better than the curve 65 score to determine where to put the patient into it. So once you have identified that the patient goes to the outpatient, the patient can be treated as an inpatient or non-ICU hospitalized patient, and that is a ward patient and a outpatient management. So we're not really going to be talking about too much about outpatient management. Because that is not where we don't as intensivists don't get involved. We as pulmonologists or physicians might get involved in this care of this patient, but we intensivists are generally, when we working as an intensivist, we only are seeing patients who are hospitalized into the ICU, and we really need to know how to treat severe cap. All right, so the most identified is to cover the core pathogens as we talked about, or you can say look at cover three most common pathogens: that's strep pneumo, and most of the relevant Enterobacteriaceae species, and two atypical pathogens. And you need to be specific and ask for risk factors of MRSA or Pseudomonas aeruginosa, and then add coverage for MRSA. So for an ICU treatment for strep pneumo, staph, H influenza, Legionella, gram-negative bacilli, and this gram-negative bacilli does not include resistant CREs or ESBLs. We're just talking about regular Klebsiella, regular E. coli, which is present in the pharynx of somebody who's come into ICU with a severe cap. So again, for this is an intravenous beta-lactam like a ceftriaxone plus a macrolide. We don't advocate fluoroquinolones in our country because of the prevalence of tuberculosis. And if you have risk factor for Pseudomonas like structural lung disease, bronchiectasis, cystic fibrosis, antibiotic exposure in the last 90 days, then you can use an anti-pseudomonal beta-lactam plus either a macrolide, which means a piperacillin tazobactam plus either plus an azithromycin, or an anti-pseudomonal quinolone like again not recommended because of tuberculosis. And risk factor for community-acquired MRSA we'll talk about is to add vancomycin or linezolid because of the in addition to the ceftriaxone plus the azithromycin that we were talking about. So when you look at the risk factor for Pseudomonas, they require structural lung disease, repeated exacerbation of COPD, frequent steroid or antibiotic use, and prior antibiotic therapy. Again, for this, you can use piperacillin tazobactam, imipenem, meropenem, plus either a high-dose ciprofloxacin or levofloxacin, or a beta-lactam plus an aminoglycoside and an azithromycin. So any of these combination can be used, and this is what is suggested by various guidelines, whether it be the Indian guidelines or the IDSA guidelines. All of them will say the same thing. For MRSA, again, it's the risk factors include preceding influenza, what we used to call double pneumonia, injection drug use, although it may present in patient without any identifiable this thing. But we should be suspecting when you have a suspicious gram stain, that is gram-positive cocci cluster, when there's a conventional pleural therapy failure, pleural-based lung nodules suggesting pulmonary emboli or cavitary lung lesions. With cavitation, you're worried more of TB also in our country, but staph, MRSA should be the more worrying thing in a patient who presents very acutely and who's very sick. So this is the time when you look at a chest X-ray or peripheral lung nodules in addition to a mnemonic patchy consolidation, please think of MRSA. So inpatient non-ICU is the same as a treatment remains the same, organism remain the same, except you're not covering really for the enterobacteriaceae with the intravenous bactalactam plus a macrolide. Again, if you are on a severe, for severe cap who are on ventilation or septic shock, if you have presence of risk factors or no, you ask yourself, do you have presence of risk? If you don't have it, so this is the algorithm which we just talked about. If you don't have any risk, severe cap, then you can say, are you at risk for cap for Pseudomonas? If no, risk for MRSA. If no, just the core pathogens. If any of this is yes, you cover for MRSA plus Pseudomonas. And for severe, when you start off, you always cover for core pathogens plus Pseudomonas and MRSA, and that's what you would do. So that means you're gonna give a most commonly in our country, somebody who has CAP and is on a ventilator, is on septic shock with norepinephrine, we would give them a meropenem plus azithromycin or doxycycline plus a vancomycin or a teicoplanin. And that's the standard treatment for a severe community acquired pneumonia requiring mechanical ventilation. And if you're not having these things, but you're CAP in a hospital or in an ICU, but without major major criteria of the ATS, then you will go down this algorithm. Again, this is all borrowed from the NEJM review article on CAP. You're free to take a look at this. Again, the CAP start study, again, look at whether if you don't give atypical coverage for non-ICU patient, is it going to harm, and there's no difference in mortality. So for non-CAP, for CAP patients in the ward, you can just get away with just a ceftriaxone also. And the more important thing is obviously de-escalation, especially when you have a viral pathogen. So you come in and you have a comprehensive panel saying that you have a respiratory syncytial virus. So do you, but at the same time you have identified a viral pathogen, but you have a there is no concomitant bacterial pathogen on the PCR, but your radiology is suggestive of lobar consolidation or a dense alveolar infiltrate, then you will continue therapy for CAP. If not, then if you have a high WBC, you will still continue therapy for bacterial. If you have a high CRP, you will still continue therapy. If your procal is more than 0.25, if you have evidence of clinical deterioration, you will continue therapy for bacterial cap. If you have none of these, that means if you don't have radiology suggestive of bacterial, high WBC, high CRP, high PCT, and no and clinical response, then you can stop the treatment of a bacterial cap and just finish and assume that this is purely viral and finish and discharge the patient very quickly within 48 to 72 hours. And this is a de-escalation program that we strongly suggest. The other important thing from a quality control is the time to first antibiotics. The idea is that in CAP also, like in surviving in septic shock, like within 1 hour. So in severe CAP, obviously the same would apply when you are in vasopressor shock. You have to give the antibiotic as soon as possible. 45 minutes is the max. And for non-shock patient or patient non-severe CAP in the ICU, again, there's very sure that you have to admit them, give the administration of the antibiotic while they're still in the emergency department. That means within the first 4 hours of their admission to the hospital. Again, though the early administration of antibiotic does not shorten time to clinical stability in moderate to severe, but in severe clinical community-acquired pneumonia, it does shorten and makes a huge difference. There are certain adjunctive therapies. The number one most famous one was the Zygris or the drotrigogen alpha, which the ProVest study eventually said that first there was a benefit, and then subsequent analysis said that there is no benefit, and therefore initially we used to use this a lot, and there was a publication in 2005 which said that if your Apache is more than 25, you're going to benefit. But from 2009 onwards, we know that it's an end of an era and we've stopped using it. But what we are using now more and more is the hydrocortisone infusion for severe CAP. This was the first study in 2005, a small randomized study, 48 patients only, 37 continuous infusion compared to placebo. Again, steroid therapy led to a significantly lower mortality. We have noticed that in severe CAP, because of COVID, dexamethasone has a significant benefit. But we know in H1N1 and in aspergillus, there might be a poorer outcome if you use steroids in that situation. So, but pneumocystis, there is benefit. So, in severe CAP, which is typical to a core pathogen, the new study published in NEJM in 2023 shows a benefit benefit of survival, especially in severe CAP, that is, who are on in the ICU and are on a ventilator, or patients who are at high risk of respiratory failure. If you treat them with a dose of hydrocortisone daily, 200 milligrams, you have a survival benefit in severe CAP. So if you're severe CAP, non-H1N1 or at core pathogen is there, which may be influenza, maybe again, maybe not influenza, maybe you giving CAP treatment with corticosteroids may show improvement. The ATS guidelines published in 2019 did not recommend, but these are now the newer papers, the DEXA study with the COVID and this CAP paper in New England Journal of Medicine in 2023. So these guidelines may vary, where they said not routinely use. Maybe now it will become that we suggest routinely using corticosteroids with severe CAP. And surviving sepsis guidelines always work for hydrocortisone. That means when you're in septic shock, go ahead and use hydrocortisone for the same principle that you will do it in sepsis. All right. So if you have CAP with ARDS, the role of steroids, as I said, once you develop ARDS, again the first week, if it is a COVID associated, then yes. Or now, if you use these guidelines, if you have severe requiring mechanical ventilation, probably we'll give hydrocortisone 200 milligram per day, and just follow the guidelines for mechanical ventilator management with ARDS. Last bit is what happens to this patient is somebody who has had left-sided pleuritic chest pain. He is injected heroin user. Sputum is already showing gram-positive cocci in clusters, so he thinks it is in a staph aureus, and his sputum is blood culture is growing MRSA, and he's on vancomycin therapy, but he's still having spiking temperature despite 3 days of vancomycin-appropriate antibiotics. And the vancomycin trough levels are all right. Transthoracic echo doesn't show any vegetation. What will you do to treat this patient? So this is something which is important, is that you need to recognize the why there is a treatment failure. The treatment failure is not that the MRSA has become VRSA and you need to change from dicoplanin to linezolid. But when you see an X-ray like this, you can see that there is probably a pleural effusion, and this is probably an empyema. So when you have a non-resolving CAP, that means you have appropriate antibiotics for 48 to 72 hours. You have to think of either the organism is resistant, which is what, but in this situation, layer, or an atypical organism, or a loculated infection such as an empyema. This is what we are more worried about in the X-ray that I show, or that it's an infection mimic like something like a tumor or a pulmonary embolism or a vasculitis that is happening. And anybody who has a significant pleural fluid collection like this one that we have shown you here in this X-ray should undergo a diagnostic thoracentesis and chest tube drainage if it is empyema. So the complications of CAP can be listed as pulmonary, which is non-resolving pneumonia, like the one we just, because of an empyema. Lung abscess can happen, which will require or an ARDS. These are the 4 main pulmonary complications of pneumonia. Either pneumonia doesn't fail to resolve, if it can develop into an abscess, you can have a pleural space infection with a pneumonia, which is called an empyema, or you can have ARDS. Neurologically, you can get delirium. Hematologically, leukopenia, thrombocytopenia. Cardiac, you can see acute coronary syndrome, 5 to 10% of hospitalized patients, and this is what we see, especially with H1N1 infection. Post-flu acute coronary syndrome is notorious. Very significant atrial fibrillation complicates the stay of almost 10 to 15% of patients with hypoxia and pneumonia. Acute kidney injury, again because of antibiotics, because of medications, and adrenal insufficiency or a Waterhouse-Friderichsen syndrome can occur in the context of a severe septic shock, where you can have that. So the management as of now is to make sure that for any CAP who's coming into the hospital, you need to have first dose of antibiotics within 4 hours, oxygenation assessment within 24 hours, correct antibiotics as per the guidelines, blood cultures to be drawn, and at the discharge, offer them pneumococcal influenza and smoking cessation advice. All right, to quickly summarize, in India, we really don't know the epidemiology exactly, but we know from the outside world, in the US, it's the 6th leading cause of death. It's the most important cause of infectious disease death in the US as of now. Curb 65 and PSI are valid in Indian scenario to identify where to place the patient. Curb 65 is a much easier to use. The IATS criteria is also very useful to decide ICU versus non-ICU. Microbial etiology shows importance of Enterobacteriaceae, Mycoplasma, and Legionella in our country also. Can't ignore it. And TB presenting in CAP data is scanty in our country, but there's good data from third world countries like South Africa, where cat TB is also epidemic, and that can present. But then South Africa also is plagued by HIV epidemic, so you might have a bias out there also. But in our country, about 1 to 2% of cap would be about TB. And management guidelines as of now are a rehash of Western guidelines. The Indian ICMR, as well as the Indian College of Chest Physicians, all have a very good guidelines. The ISCCM also has good guidelines, and we talk about ceftriaxone plus azithromycin. And if you're worried about, and as I said, the when you are severe cap with pneumonia or septic shock, to cover for core pathogens and to cover for some more pathogens like the for risk factors for Pseudomonas, and for in our country and ESBL Enterobacteriaceae, is fair enough to do that, and that's something which we should be. Thank you very much for your kind attention. I took about 55 minutes to finish a long presentation and had a lot of information. Hope you would be able to go through this and go it in and present it, and to understand the clinical signs of pneumonia, the various microbiological agents, how to evaluate diagnostically and management, and strongly suggest that you read the review article of CAP published in NEJM in 2023. Thank you very much.
Thank you,
Thank you,
sir.
sir.
Thank you very much, sir. It was a very
Mhm.
informative session. Uh, I would request the aspirants, if they have any question, you can ask now.
Hello, sir. Hi, good evening.
Yeah,
I'm
hi.
Dr.
Great.
Akhilesh. How are you, sir?
Very good, sir. Mhm.
Yeah. So it was very informative and very exhaustive and very important aspect that you have come up with. The CAP is still probably not very well understood entity. I still believe probably, and the pathogens that are associated are still very dubious, and we really need to keep hunting them because most of the times the culture negativity is an important problem that we face all the time. So when you have culture negativity on repeated sampling, how do we treat such infections? Because the yield of the organism is also very important. And sometimes, in spite of the best sample collections through bronchoscopy or even through bronchial brush biopsies, we see that the adequate growth or the organisms are not identified. How do we treat in culture negative community acquired pneumonias? So, do you have anything to say on this, sir?
So community-acquired pneumonia, as I said, more than for even for severe community-acquired pneumonia, that's the only time. Even then, the blood culture yield is only 10%. And as we talked about sputum is not available in a lot of patients. ET will be negative. So the recommendation is that you have to treat the core pathogens. If they are not responding for core pathogen coverage within 48 to 72 hours, you need to move to the non-responding, non-resolving pneumonia algorithm. So you did change that. So the first 48 hours you will not do a bronchoscopy. When you get a cap, 48 to 72 hours, only when there is a bronchoscopy is a non-resolving pneumonia, then you would go ahead and do the further diagnostics of community acquired pneumonia. So if you are doing diagnostics of including bronchoscopies and brush specimen, then again, one of the most important thing to remember is that this might be a non-infectious pneumonia. We do see organizing pneumonias. We do see COP, like BOOP or COP, whatever you want to call it, is a very important thing where you have patchy segmental consolidation and more than 2 weeks there and antibiotics are not responding. So you need to be worried about those kind of a things. You need to be worried about atypical organism, which are not only tuberculosis, funguses, and all those things need to come up with. So yes, so what we suggest is that if you get a cap, irrespective of whether you should send in case of blood cultures, in case of severe cap, otherwise don't bother. And once you have a severe cap which is not responding in 48 to 72 hours, then you need to go into the non-resolving mode, get a scan, make sure there's no collection, no lung abscess, and then plan your further management is what I would suggest. Right. So I
Oh,
think
yeah.
yeah,
Yeah,
there are a
that
lot of
was
other.
very
Uh,
important. Yeah. There are
so I
some
think
other questions in the chat box.
yeah,
Hi,
I'm
Dr.
seeing.
Asif, how are you? Good evening. Can we take few questions from the chat box?
Yeah,
Yes,
yeah. So I
yes.
see there's a question on anticoagulant in severe cap. Again, uh, uh, probably no. The still DVT prophylaxis would be this thing. There was initial lot of interest from, especially in the era of Zygres, also to use heparin for severe cap. As of now, the IDSA and any of the guidelines do not suggest it. Antivirals, if you have certain thing which is available for H1N1, you should start it immediately, or influenza COVID, for severe COVID, you should start immediately. If they are not ventilated and not requiring oxygen, even now antiviral therapy may be useful in the first 48 72 hours. Inhalational antibiotics role, not much in, at least in community acquired pneumonia. No, if we talk about VAP, there might be something, but not in CAP. Lung ultrasound to diagnose pneumonia, yes, absolutely. Again, B lines are again non-specific. Um, um, and again, as I said, looking at shred sign, looking at a consolidation and a lobar pneumonia, it's very easy to diagnose that with a lung ultrasound. So yes, it's a part of practice to do a lung ultrasound in all patients with dyspnea, all patients with shortness of breath who comes to the ICU. Blood culture should be done in all severe cap. That's the guideline suggestion. Comparing dexamethasone to hydrocortisone, dexamethasone has been studied for ARDS in cap, as well as dexamethasone has been studied for the COVID. The two trials for steroids and adjective are used hydrocortisone. So I don't know what to tell you, but as long as you use equivalent amount of 200 milligrams of hydrocortisone per day, everything should be okay. For MRSA, we prefer linezolid or vancomycin. Linezolid is to be reserved for VREs and things like that for a later date, but we don't really reserve anything for. So you can use linezolid. It's got a good alveolar epithelial fluids concentration. Only thing is it requires a large amount of volume, and it can cause thrombocytopenia. So if you don't have that, glycopeptides are the safest to go only, and is one of the things that I think I answered 5 or 6 or 7 question. Difficult to treat strep pneumonia. DRSP rates are climbing up. Add vancomycin if you find that your DRSPs are, if your strep pneumo is taking a long time to get healed. And last question is how to differentiate between colonizer and true pneumonia. As I said, that is always clinical. So if you have a compatible clinical symptom and a compatible clinical sign, then the radiology and a compatible radiology with an organism, then it's a true pathogen. If you don't have any of those things, any one or one or two only and not three, and then you have a pathogen, then you don't know what you're dealing with. Hope I answered most of the questions, and all the questions were there. I think I put an answer. Um, Staph, we talked about targocid and vancomycin in staph only if you have risk factor for MRSA. That means if you are going to be concerned about you have a cavitation or nodules on your chest X-ray, or you have had recent influenza pneumonia or recent heavy antibiotics in the last 90 days, then I'm considering coverage for MRSA, and then I've had a teicoplanin or a vancomycin. All right, Asif, I hope.
There is one question pertaining to inhalational antibiotics. I don't know whether this has been answered or not.
Yeah, no,
Yeah.
in CAP, no role. In HAP and VAP, you might have certain. You can probably think of it in VAP, but again, the in CAP, no guidelines, no need to add add an aerosolized antibiotic. You're not going to do anything different, and unless you have a pseudomonas, and probably the only situation would be a bronchiectasis or a cystic fibrosis. So if you see a structural lung disease where you have pseudomonas, there probably tobramycin nebulization may be a useful adjunct to eradicate the infection completely, but not in a non-structural lung disease. I'm probably not going to be using inhalational antibiotic in a cap.
And that too, routine inhalational techniques with that nebulizer is not sufficient, probably. We need to use ultrasonic nebulizers or, the nebulizers which can produce the particle size less than 5 microns. Probably that may be useful. So, but do you still recommend that the way we nebulize with our routine nebulizer, can we still continue inhalational antibiotics through that nebulizer?
No, as I said, you rightly said, you need a mesh nebulizer for a good, effective this thing. Jet nebulizers are not very effective to deliver particles into the this thing, and especially we will not know what drug or what dose is actually getting into it, what kind of particles. Toba mist is probably easy to do it because it comes as a respiratory solution. But when you use vancomycin, which is a powder which we make it into a dissolve it and then put it in things like that, then it becomes difficult. But if you're using things which are already coming as a solution, like tobramycin, it becomes very easy to take care of it because that's then you can probably get away with it. But things which are a powder in which we reconstitute and then put it into this thing like a colistin, then you need a mesh nebulizer.
Oh, yes, that's fantastic. That's fantastic. There is one more question: how to differentiate between colonizer and true pneumonia? So it's
As it
about the quality count, probably. Yeah, yeah. Please highlight about this.
I think you really one is that most of the hospitals should report only when there's a moderate to heavy growth and not report scanty growth. But I think it's eventually it's all clinical. So as I said, if you have an appropriate clinical signs and radiological finding, then whatever you grow is the true pathogen, irrespective of the amount. But if you don't have any one, either the clinical symptoms are not matching, signs are not matching, or the radiology is not matching, then you have to take a with pinch of salt that whatever is growing is not a true pathogen. So, for example, if somebody has no symptom and you have an sputum culture which is growing as Acinetobacter, we know that probably is a colonizer. So it's a clinical. The distinction is clinical. Most of the microbiology labs are now recommended not to report less than scanty growth in a semi-quantitative fashion. If you're using quantitative BAL samples or sputum ET cultures or things like that, then using a 10 to the power 4 is thing. But that again doesn't make it a true pathogen unless you have a compatible clinical symptom.
Oh, thank you, Dr. Ramasubban. It was really very informative and very important discussion that we had today. Dr. Asif, you're there? Anything to speak about? Dr. Asif, are you there? I think we have exceeded the time also. Thank you, sir. Thank you for your, you know, valuable insights in the topic. I hope the audience has learned a lot from the topic today. And
Yeah.
yeah, Dr. Asif is also around. You would like to say something, Dr. Asif?
No, it's amazing to learn from Sir. He's my
Yeah.
teacher. So I always prefer to get up, always find get opportunity to learn from him.
Yes,
Yes,
sir.
yes. Wonderful teacher, wonderful orator. Kudos to you, sir. Thank you. You must have
Thank
taught
you.
so many students, and it was really a great platform for us, all of us, to have the insights about the topic from you today. And can we wind up, Dr. Asif,
Yes,
if
yes, yes.
there are no more questions?
Yeah. Thank
We'd
you,
like to
sir.
see you again, sir. Hope to see you again and again and
Sir,
learn from you again and again.
you have to take the case presentation on this pneumonia, community acquired pneumonia and sepsis, sir.
Will do.
We
No
want
problem.
to
But ask somebody to present it.
learn from that
No,
opportunity
no,
also.
no. No problem. All right. Take care. Thanks very much. Sir.
Thank
Sure,
you,
sure. Thank you,
all.
audience. Thank you. Thank you. Bye
Thank you,
bye.
all
Good
the
night.
doctors present here. Thank you, Dr. Suresh sir, and all the aspirants. It was a very nice and informative session. We will uh, we will have the case-based discussion soon on the same topic. Thank you.